Okay, good evening, everyone. My name is Brianne Roby, and tonight I'll be the moderator on a webinar called Global Approaches to Common Otolaryngology Problems. This is an initiative for the American Academy of Otolaryngology Head and Neck Surgery Foundation with the Humanitarian Efforts Committee sponsoring this. And specifically, it's our subcommittee for education that really has been working hard to develop some content on education in global sections. Tonight, we have three different colleagues who are going to be joining me on this wonderful webinar. The agenda will include the first topic, Jeopardy in the neck, the utility of surgeon performing ultrasound and management of neck masses, sudden sensory neuro hearing loss, and an infant with noisy breathing, cross-content, and shared curriculum building in global ENT. I'm joined by three amazing colleagues. First, we have Mary Sebelik, who's joining us, and she's got her colleagues that I would love you to give just a little background on your connection with them, Mary.
Yes, my connection with Dr. Luna and Dr. Capuz goes back to 2011. They took an ultrasound course at the Academy back when we were giving the American College of Surgeons course. They flew to San Francisco from the Philippines and brought it back home and started teaching it to their residents at home, and have really now become the premier ultrasound educators in the Philippines and around Asia. And so they have been excellent collaborators with me. They work on simulation. They work all over the Philippines, teaching other residency program ENT residents how to perform point of care ultrasound. And they're just amazing and energetic, and I get so many good ideas from them.
That's great. Well, I'm excited to hear more from them shortly. Next, we have Dr. Greg Basura, who is not only has been the chairman of our Global Humanitarian Efforts Committee for the past couple of years, but has been a real advocate in global education. He is now at the University of Pittsburgh Medical Center, and we'll be talking about approach to a patient with sudden sensory neuro hearing loss. Dr. Basura, I'd love to hear from you on your connection with your colleague.
Great, thanks, Brianne. So I had the opportunity to present today with my colleague, Dr. Amina Seguya, who's actually an otologist now. She's actually our current fellow at the University of Cape Town, which was established in 2022. She's from Kampala, Uganda, and she'll be graduating in January of 26. And so the fellowship we started there 4 years ago now has produced, now will be our fourth fellow, designed for training of Africans for Africa. And so one of the goals of the fellowship is also, as we train African surgeons across the continent going forward, is to develop future fellowships, which I'm honored and proud to say that she's been, her university was just awarded the opportunity now, or the certification, to be our second otology fellowship on the continent. So when she returns, she'll be starting that. But it's also an opportunity for us to develop resource-centric guidelines. So as we expand our training capacity across the continent, one of the goals that we have, like that's showcased here with this particular webinar, is how can we design resource-centric education and principles that are surrounded in areas of the developing world that best suit them for the practice patterns they need.
Great. Thank you. I'm excited to hear this one as well. And next, I have the pleasure of introducing Dr. Siva Chinnadurai. He is going to be presenting on infant with noisy breathing, across context management, and shared curriculum building in global ENT training. And I get the good fortune of working with Dr. Chinnadurai on a daily basis to see all the amazing global education work that he has been passionate about as well. So, Dr. Chinnadurai, do you want to give a brief background to your colleague?
Yeah, thanks, Dr. Roby. I got the pleasure for this webinar, as I do often, of talking with my colleague, Dr. Kassaw, who is a otolaryngologist in Bahidar, Ethiopia. And he is the head of the Department of ENT but he is also our first pediatric ENT fellow in the fellowship program that we co-founded between our NGO here, Children's Surgery International, and Bahidar University College of Health Sciences and Medicine. That partnership dates back 10 years. This is actually our 10th year, and we've made a lot of good connections and partnership that's helped us kind of integrate into the community and build capacity. And a few years ago, we had the opportunity with some national recognition that the university got and interfacing with the federal government to create an accredited fellowship. You know, Ethiopia as a country has over 60 million children, but despite that, there's only one pediatric otolaryngologist in the whole country. And kind of from top to bottom, people saw the opportunity and the need to invest in that, and it's been an honor to do so. And so we'll talk about a case and how that program got built and is going forward with Dr. Kassaw.
Right. So next we are going to be sharing with you all some videos of each of our panelists tonight and their colleagues to show kind of how they've built some curriculum building and more importantly, how they manage complex common problems within pediatric otolaryngology, otology, and head and neck that need to be managed in different ways. Because as we all know, there are different resources available across the world, different levels of training. And so this will be hopefully a really great videos that they share, some conversation, and then at the end we'll wrap up and hear from our panelists again.
Hello, my name is Mary Sebelik, and I'm a head and neck surgeon at Emory University in Atlanta. And I am delighted to present this educational webinar on management of neck masses around the globe with my co-authors, Doctors Karen Capuz and Geraldine Luna, pictured here. And we are presenting this educational video in a pseudo Jeopardy format. This, of course, reflects our overall title, Jeopardy in the Neck, and a little bit more about my co-authors. Dr. Capuz is an assistant professor in the Department of Otolaryngology in the University of Santo Tomas, Faculty of Medicine and Surgery in Manila, at which she is also program director for otolaryngology residency training at the East Avenue Medical Center. Dr. Geraldine Luna is a thyroid interventionalist and educator extraordinaire who practices and teaches PEI and RFA of the thyroid, and she is in practice in the Asian Hospital and Medical Center in Manila in the Philippines. And as said, I am an endocrine head and neck surgeon in Atlanta, Georgia. So our first case is a woman who presented to a goiter clinic in Manila for surgery. She had already had a radiology performed ultrasound, which described her multiple thyroid nodules. She was actually taken into the operating room and put to sleep for thyroidectomy, but the astute surgeon noted that the goiter was pulsatile. And look at this video here. So the answer is, normally located in the upper mediastinum, this pulsatile structure can mimic a thyroid mass. The question is, what is the innominate or brachiocephalic artery? When this is reviewed, as in this case, which used CT data to describe the prevalence of innominate arteries superior to the suprasternal notch, this was observed 53% of the time, and 1% were more than 3 centimeters above the notch, as in our patient. This large artery poses a risk during tracheotomy and thyroidectomy, and particularly if it is not identified. This patient's radiology report only reported on the thyroid, did not mention any vascular structures. So this surgeon's observation skills and pre-incision ultrasound helped avert a disaster. The next case is a neck mass in a child from South Africa, and this mass is cystic and located in the midline at the level of the hyoid bone. And here is a video of the ultrasound that showed a hypoechoic or dark structure with white sparkles in it in the anterior neck. The question is, what is a thyroglossal duct cyst? Congenital neck masses look very distinctive on ultrasound, and that, coupled with the location of the neck, really help make the diagnosis without additional workup. Ultrasound appearance of a congenital neck mass is distinctive with a very smooth border, a very dark or hypoechoic center with proteinaceous debris that can have a comet tail artifact, and it's described as a starry sky or falling snow, such as in this photograph. You can see that the distinctive protein clumps with little tails behind them are very, very suggestive of a congenital neck mass. Here is another cystic neck mass in a man from Ghana who has a sore throat and there is some concern for malignancy. You can see this ultrasound picture shows a hypoechoic mass with some posterior enhancement and distinct borders. The question is, what is a metastatic lymph node from HPV-associated tonsil cancer? In this review of HPV-related cancer epidemiology throughout the globe, it was reported that HPV-related oropharynx cancer was noted in 50% of oropharynx cancers in Ghana, 19% in Rwanda, 5% in South Africa, and none in India. Whereas this may reflect the true prevalence, it is more likely to be reflective of the difficulty in testing for HPV in oropharynx tumors. In the United States, in 2008, HPV overtook alcohol and smoking as the #1 cause of oropharynx cancer. The differential diagnosis of cystic neck masses in the adult also includes metastatic papillary thyroid cancer, as well as tuberculous adenitis or delayed appearance of congenital neck masses. So this is a representative ultrasound of the primary. This patient on CT scan has a base of tongue cancer, but that is also visible on ultrasound of the neck. So here's another patient from Ecuador. This patient had a lateral neck mass, and when a needle biopsy was attempted, the syringe filled up with a lot of bright red blood. And here is the video of the neck mass. So the question is, what is a carotid body tumor? Carotid body tumors are seen at increased rates in high altitude countries such as Bolivia, Ecuador, Mexico, Spain, and Kenya, per this review article. It has a very pathognomonic ultrasound appearance. When you look at the neck transversely at the level of the carotid bifurcation, you'll see the mass splitting apart the internal and external carotid arteries. And when you turn on vascular studies, you'll notice that that soft tissue mass is very vascular. You should avoid a needle biopsy, and it actually shouldn't be necessary. But if one is inadvertently done, pressure alone is enough to mitigate any bleeding from the needle biopsy. These neck lumps were present in a thin 24-year-old Ethiopian female farm dweller. So remember those characteristics in the stem. And this ultrasound video shows a number of neck lumps that are very heterogeneous in appearance. They're surrounding the internal jugular vein, which you can see as a dark structure on the right lower corner of this video. The neck lumps are oval, and they have some indistinction from the surrounding tissues. The question is, what is tuberculous adenitis? In this review of the infectious causes of cervical adenopathy in low and middle income countries, it is noted that TB is common. It is most often in the neck, it's matted and mobile, and that ultrasound appearance coupled with ultrasound-guided FNA is very useful for diagnosis. This particular article reported that Ethiopian rural farm workers had the highest observed rate of tuberculous adenitis, which also had the lowest rates of co-infection of TB and HIV. So this next case, these neck lumps are present in a 40-year-old female from South Africa. She has weight loss and night sweats and has recently tested positive for HIV. And you'll notice on this ultrasound video that the neck lumps are very different in appearance to the last case. They're round, abundant, very dark. And in fact, the question for this patient is, what is non-Hodgkin's lymphoma? Causes of cervical adenopathy vary widely across sub-Saharan Africa per this very nicely done review article. And it showed that ultrasound appearance coupled with ultrasound-guided FNA was very useful for differentiating infection from cancer in South Africa. Their rates of etiologies included carcinoma at the top, followed by lymphoma, followed by granulomatous inflammation, followed by HIV inflammation. And that in the HIV infected patient with lymphoma, it was most often a very high grade lymphoma. And these are some representatives of the different appearances of the different etiologies of neck masses from in sub-Saharan Africa. This is another video of lymphoma to show you the pattern recognition. When I see this, I am reminded of a pile of ping pong balls, and this is so pathognomonic. I know to get ready to do a core needle biopsy to do studies for lymphoma typing. So this next case is a young Kenyan man who presents to you for management, and you use your ultrasound to aid in the differential, but I would pose that just his physical examination and history tells you what this is likely to be. He has long-standing neck masses under his chin and jaw, and he has a soft compressible mass within the floor of mouth. This is non-tender. And he was taken to surgery after imaging was obtained, and this is a picture of him after he completed excision. The question is, what is a plunging ranula or a sublingual sialocele? Plunging ranula is a pseudocyst of the sublingual gland that herniates through the mylohyoid muscle, which are structures you can see on ultrasound. In this nice review out of New Zealand, it was noted that patients of Maori and Polynesian origin were more likely to be the ones presenting with a plunging ranula. And they reminded us that this does need to be removed through the neck and not through the mouth to prevent recurrence. This is a little reminder of what the ultrasound looks like in the submental triangle where the sublingual glands live. And whereas you can very easily see the muscular structures within the submental triangle, and when you look for the sublingual arteries, you can see that this pattern looks like Mickey Mouse. If you look further, you'll see that the sublingual glands are also visible, and you can see how, if they herniate through the mylohyoid, it can enter the neck structures under the skin. Continuing with salivary gland, this 50-year-old woman from a rural town in the Philippines noted a mass in her neck for many years. She was unable to pay for and obtain a CAT scan, so she was taken to surgery. The question is, what is a pleomorphic adenoma? Parotid neoplasms are very easily characterized on ultrasound, and we know that the most common histology is pleomorphic adenoma of the parotid, which grows slowly and can grow to enormous size. Carcinoma X pleomorphic is a rare malignant transformation of pleomorphic adenoma, and it is highly aggressive, so removal while it's in a benign state is recommended. In this nicely done review article from Senegal, Dr. Evelyn Diam is the first author, who is one of the past presidents of the African Head and Neck Society. She noted significantly that parotid tumors are still most likely to be benign, but at a lower rate than that seen in high-income countries. This is an ultrasound picture of a pleomorphic adenoma with a very distinctive border, hypoechoic echogenicity, and posterior enhancement. And I'm closing this out with a reminder of a keynote address that Dr. Mark Schreim gave for the American Head and Neck Society in recent years while he was the O'Brien Chair of Global Surgery at the Royal College of Surgeons in Ireland. And his keynote was about the right to look human and how we need to have access to head and neck surgery in low and middle income countries. His index case was this unfortunate rural Malagasy farmer in his 60s who had a very large pleomorphic adenoma that had grown for years and years, but was able to successfully be excised with Dr. Schreim's group. So in conclusion, I'd love to thank you from my co-authors and myself. This is a testament to how often we try to disseminate ultrasound education to surgeons in different parts of the world. This was our most recent course I was delighted to participate in on August 23rd in Iloilo at the Western Visayas Medical Center. My co-authors and I are pictured here, and it was a lovely large group who learned a lot about surgeon-performed point-of-care ultrasound in management of diseases of the head and neck. And I thank you very much.
All right. Well, welcome. I'm joined by my good friend and colleague, Dr. Amina Seguya from Uganda, who is our current Cape Town Otology Fellow. I'm Greg Basura, current chair of the Humanitarian Efforts Committee through the Academy of Otolaryngology. I'm honored to present today with my colleague regarding an approach that we commonly see in multiple clinics across the world, and that specifically is how do we manage sudden sensorineural hearing loss. So today's plan is to present a patient and then discuss how we might manage this in two different countries, and then to tie that off to bring that together and think about curriculum. How can we bring back best practices to optimally treat patients like this, regardless of the setting, or to be more sensitive to resource constraints that might alter what we would optimally treat. So with that, I'll leave it over to Amina to begin the presentation, and we'll start our discussion. Amina, thank you so much for being on the call.
Thank you, Dr. Basura. So I'll just briefly talk about how we teach and how we approach a patient that has sudden sensory neural hearing loss at my unit in Uganda. I have no disclosures, and usually this is how we'll approach it. So we'll consider sudden sensory neural hearing loss as an emergency, as an ENT emergency, and we'll define it as a loss that is greater than 30 decibels in 3 or more adjacent frequencies occurring within 72 hours. Commonly, this is going to present unilaterally, and the etiology is various, as we know. Some of these we are able to investigate for, but some we are not able to investigate for. However, there are things that are very common that we need to ask the patient about. So one, you have to take a very extensive history about the onset and progression of the symptoms. How did it start? Were there any risk factors? Looking at the etiology, was there any trauma, barotrauma, physical trauma, either to the ear or to the scalp? Any acute sudden exposure to loud sound? We ask about ototoxic drug use. And we also ask about other associated symptoms like vertigo, tinnitus, ear discharge, and we are trying to tease out what the cause could be. We also ask about the common comorbidities like hypertension, and if the patient is hypertensive, what drugs are they taking? Here we are very interested in knowing if they're on loop diuretics. We also ask about renal disease, if they are on dialysis, if they are on any treatment for hematological malignancies or any chemotherapy. We also ask about autoimmune inner disease in the quick history. A full ENT exam is very important, and on otoscopy, we want to rule out any outer ear pathology that could explain the sudden hearing loss. And commonly, you'll find things like foreign bodies or even wax, even an eardrum perforation in this ear, and that could guide you as to why you're having the sudden loss. We have pneumatic otoscopy available to us, and we are looking at the compliance of the middle ear. If the drum is moving, then that rules out things like otitis media with effusion or even eustachian tube dysfunction. A general ENT exam is important, especially in the neck. We rule out any masses or lymph nodes that could explain why we are having this sudden loss. Oropharyngoscopy is very important. It will guide you towards any masses present, but also to quickly assess the lower cranial nerves, cranial nerve 9 and 10. Nasoendoscopy is important. We look at the nasopharynx, rule out any masses in the posterior post-nasal space. We look at the fossa of Rosenmüller if we have any feelings, and sometimes a mass there is obstructing your eustachian tube. So that guides you on what the possible diagnosis is. Fiber optic laryngoscopy is also important in assessing of the vocal cord mobility. If you have any paralysis or paresis, sometimes this may not be noticed by the patient, especially if they have been compensating, but it will guide you to possible intracranial causes of the sudden sensorineural hearing loss. So bedside, your tuning fork exam is very important because this is going to be your first confirmation that you actually have a hearing loss. So we'll do the Weber's test and the René's. So if we have a sudden sensorineural hearing loss in the right ear, we expect the Weber to lateralize to the opposite side, and the René's in that ear will be positive. So that gives us the first understanding that we actually have a loss in the ear. We do a full cranial nerve exam. This is very important, more so to rule out intracranial causes of the sudden sensorineural loss. So any patient that has cranial nerve fallout, then there is a higher possibility that we could be dealing with an intracranial cause of the sudden sensorineural hearing loss. Vestibular assessment is important, especially if the patient presents with imbalance, and your head impulse test is a quick test that can help you rule out retrocochlear, because more importantly, we are worried about an acute vestibular insult or acute stroke of the posterior fossa. So your head impulse is very important in ruling out that emergency. And most of the examination is tailored based on how the patient presents, but these are key when we approach a patient with such. Audiometry is important. Urgent audiometry will help us confirm the diagnosis. We'll be able to see that there is a sensorineural hearing loss, but also it would help us act as the baseline as we manage our patient. Speech audiometry is available in Uganda, however, not in all centers. And we can look at the speech discrimination score. We can also look for a presence of rollover. If we have a discrepancy between our pure tone average and the speech discrimination and the speech reception threshold, then we are most likely thinking about a retrocochlear cause for a sudden sensorineural hearing loss. Presence of rollover is more common in retrocochlear pathology, so we'd look out for that as well. And if we have previous audiometric results, we will compare and confirm that actually we do have a loss, or if we don't have results from before, we'll compare the current results with the opposite ear and look for any changes. We'll assume the opposite ear is normal and subjectively go with what the patient is telling us. And our management, we follow the current recommendations from the AAO guidelines, and our first line is the oral corticosteroids. If a patient has presented to us within the first 14 days and they have no other contraindication to using systemic corticosteroids, we'll start with oral prednisolone, and usually we'll give a dose of 1 milligram per kilogram daily for up to 7 days. We don't go beyond, we consider the maximum 75 milligrams, and usually we'll give this in the morning to avoid interrupting the circadian rhythm. We do taper over 2 weeks. The evidence on this is controversial. Some surgeons will not taper, but we do taper, reducing by 10 milligrams every 2 days until we get to a dose of 5 milligrams on alternative days. Once we complete that dose of oral prednisolone, we'll book the patient to repeat audiometry. And we are going to compare this result that we have compared to the previous result. And if we have an improvement, these patients usually will give them time. If they do have an improvement, that's a good sign. We will not repeat any treatment. But if we still are unimproved at the end of our course of oral corticosteroids. Then we'll go to our second line therapy, which is the intratympanic steroids. We give intratympanic dexamethasone at a concentration of 4 milligrams per ml. We can do this as an outpatient procedure. We don't have phenol in Uganda, but we block the ear with the lidocaine and epinephrine injection. We also use EMLA cream around the ear to anesthetize the ear. So you infiltrate, wait for about 5 to 10 minutes, and then by slow infiltration, we instill about 4 to 0.6 mils into the ear. Sometimes the patient will swallow, and that opens up the eustachian tube, so you lose some of it. But since you're looking in under the microscope, you can actually feel the middle ear up. As we do this, we look for sometimes you'll see bulging of the drum, sometimes you'll see bubbles, and all these are signs to guide you that you're actually instilling the dexamethasone. We ask the patient to lie still with the affected ear upwards for about 20 to 30 minutes. And then we will repeat, after giving this dose, they'll go home and we'll repeat audiometry in 1 month. So we consider this as the salvage therapy or salvage management for the sudden sensorineural hearing loss. So we'll repeat audiometry within another month. So that gives us a period of between 2 to 3 months from the initial insult, and we compare with the first audiometry. The results are really variable. Some patients do improve, and sometimes we are unable to predict who will improve. But always, as we see these patients, there are always red flags that we have to look out for. And if we have bilateral loss, if we have progressive loss, so from the initial time you see the patient, if the loss is progressing on the audiometry or even subjectively by the patient, if we have any history of head trauma, regardless of how minor it is, that's a red flag, because sometimes we have congenital abnormalities like enlarged vestibular aqueducts, and even minor trauma is going to give them a hearing loss. If there are any concurrent neurologic deficiencies, if a patient has vertigo with any of the other cranial nerve fallouts, and also patients that have unilateral otitis media with effusion in adults, we worry about especially nasopharyngeal carcinomas or nasopharyngeal mass. We usually ask these patients to have further investigations done. And as part of our workup, this is still guided by how the patient will present to us. We can do lab tests. If there are features of autoimmune disease, we'll check for the autoimmune markers, and we'll get the immunology team on board as we manage it. If we think there is an infective cause, things like syphilis, diabetes, sometimes we have leukocytosis, and this is pointing you towards a hematologic malignancy, C-reactive protein, HIV, renal function tests. These we don't routinely do, but if the picture is not adding up and we suspect something else could be going on, we'll go ahead and do this. For patients that have had trauma, we'll get a temporal bone CT. For patients that have other cranial nerve fallouts or features of focal neurology, or any features suggestive of a possible cerebropontine lesion or soft tissue lesion along the skull base, we'll actually get an MRI for us. We don't do the MRI for every patient because of resources. We have the volume of patients is very big, so we'll try to triage and see who must get the MRI. So it's not every patient that comes in with sudden sensorineural hearing loss that will get the MRI, but patients who have the red flags, and then patients who have the progressive loss even after we've got the steroids and the oral steroids and the intratympanic steroids would actually motivate to get an MRI for these patients to rule out a central cause. If all this does not point us to a cause, and many times we do all this and it's normal, then we'll see how best to rehabilitate the patient. If their hearing loss requires them to have a hearing aid, then we'll refer them to the audiology department and they can get a hearing aid appropriate for their loss to help them with their hearing. Poor prognostic factors, and these we usually look out for, especially from history. If we have patients who are older than 60 years, patients who present late, and late is more than 7 days after onset of the hearing loss, patients who present with concurrent vertigo, usually these don't tend to recover back most of their hearing, and patients who present with profound sensorineural hearing loss at the initial presentation. These patients have been shown, these factors have been shown in studies to reduce the chances of improvement on the hearing, even when appropriate steroid doses are given. So we look out for these and we counsel our patients appropriately, but we'll still give them treatment and see how they improve. A few of them do, but many times you don't get a significant improvement in the hearing. Many of them will get improvement in hearing, but it might not get to a functional hearing level, even subjectively by the patient. And also cochlear implants are an option, especially for the profoundly deaf. Currently in Uganda, we do not implant for single-sided deafness. We look at the other ear as well. But I know in the neighboring countries, this is an option. Our preferred option is the hearing aids. And then in some of them where the hearing loss is not substantial and they still have functional hearing, we encourage preferential sitting. So if right is the good ear, if you're in a crowd, people talking should be on your right. If it is a child in school, we write a letter to the school so that they're positioned in a way where they benefit the most from the sound around them. But we continue monitoring these patients, especially looking for progression. Sometimes on imaging, you'll miss pathology on the initial imaging, but when you follow up the patient later, you might pick up something. So we continue following up these patients 6 months. Every 6 months, they'll come to us, and then we'll reassess them and see if there is any new symptoms or any new red flags that would push us to do imaging for these patients. Thank you, Greg.
Thank you, Amina. That was wonderful. A couple things. Your thoughts on intratympanic steroids. So you use it as a salvage if they're not showing improvement. So you mentioned that if someone has a sudden hearing loss, you put them on oral steroids, which is common. I think that's also utilized where in my practice, and I do about the same amount of dose and burst and taper. You mentioned if they show no response to that, then you do a steroid taper. Is that correct? Or a steroid injection, correct?
Yes. I don't offer the steroid injection in the first
at the time of, yeah.
Yes.
And I think that's fascinating because I think there's a fundamental difference there in how we manage this a little bit, which would be interesting, is that what I do is, or I think what some people do here is that, so someone takes steroids and they have an incomplete recovery. And like you said, if they don't have an audiogram that predates that, you use the contralateral ear or the better hearing ear as a diagnostic or reference point. What I typically will do is if they've had no response to orals, I don't offer an IT steroid, because my thought is if the orals at that high level, and we know it's in the bloodstream that gets in the inner ear, didn't affect that, IT steroid is not likely to additionally help. But what I'll use it as is if they've had an interval bump, but not back to where we presume they were before the loss, then there's an opportunity to salvage, showing that the steroid had some kind of efficacy. And what I'll typically do is I'll do an injection, and then similar to what you said, but we do have phenol. I'll use phenol. I'll inject the same, basically same concentration that you mentioned. And then I'll see them back a week later with another hearing test. If they've had no change from that injection, then I stop. If they've had another interval bump, I'll inject again, see them back a week later, and I'll repeat that up to a total dosing of 3 separate injections max. So that's an interesting difference there. And I think there's some controversies here, even with partners that I have, about how they do that. So I think that's one thing where we have to have a better understanding is orals versus IT, and then salvage and these types of things. The other question I have for you was, obviously imaging. In many places, imaging is done to formally rule out, as you mentioned, an inner ear or retrocochlear lesion, like a schwannoma. You're not universally getting scans per se, correct?
Yes, and the reason for us is access.
Right. Yes.
If I look, I work at the National Hospital, but the scanning services that we have are serving a larger catchment area. So we've had to modify our practice a bit to try and use the facilities that are available. And as a result, we are not able to universally scan everyone, but we've highlighted like key red flags that really those must get a scan. And even if you haven't had a scan initially, we are going to follow you up to see if there are any things of concern. I guess the difference would be who gets an urgent scan versus who gets a more elective scan, because eventually almost everyone will get a scan, but the timing would be a bit different. If there are red flags, then it will be more urgent to get the scan, and they can be prioritized, versus if we don't really think anything is happening and it's just for surveillance to make sure we are not missing something, that will be done as a non-urgent scan, which might take a couple of weeks to months, versus when we request for an urgent scan, which would happen within days.
Yeah. It's kind of similar here. I think a lot of it here in the States, there's a medical legal sort of environment here that compels a lot of folks to get MRIs on everyone. But also the data shows, the rates of schwannoma, are high enough to justify that, and that you'll find the schwannoma in a small amount of scans you get in these folks. Another interesting thing is the rehabilitation, right? So a lot of these folks that predated at least 2019 here, before the FDA approved cochlear implantation for single-sided deafness, folks were not getting implants. They were getting either nothing or some kind of a cross or bicross aid system, or maybe even a bone anchored hearing aid. I don't know if you speak to that, but in my experience, before implants were more available for that, a lot of folks didn't like that. They didn't like cross aids. They didn't think they were helpful because they certainly don't rehabilitate the ear, and they don't provide any localization, right? So what are your thoughts on that in terms of your experience with patients and maybe cross aids or bicross?
So we don't have the bicross and cross aids readily available. They have to be motivated through privately. So it also depends on if the person has good insurance cover or not. In patients where the opposite ear is normal, they don't have a lot of motivation to wear a hearing aid on this side, even when you advise for it and they have insurance to cover it. They don't, there is really not a lot of motivation. You'll suggest it and discuss it, but they won't, even when they get it, they won't wear it. And they're not readily available. They're available in just a few centers within the country, and many of the patients don't have private insurance to get that. So I don't have a lot of experience on that. Depending on the hearing loss, the ones who are more amenable are the younger population who need sound to either work or are in school, and we'll give them a conventional behind the ear hearing aid. We haven't done any bone anchored or bone conduction devices surgically for any of the patients, in my experience.
Okay. Yeah. It's a challenge, right? Obviously, to rehabilitate these folks. And I think in terms of surveillance going forward, do you have a specific, you mentioned about follow-up long-term, and, to follow up the, obviously the residual hearing that they might have that may be rehabilitated with steroids, or the contralateral ear for its sustaining health. Do you have a specific surveillance? Like you said, maybe is it an annual audiogram, or do you do it or is it more case dependent?
So for all the patients that come in, we self-educate. We teach them or their families. Anytime you have a drop in the hearing or new pain or tinnitus in the ear, you come back to us. Initially, we'll see them every 3 months. And 3 months is an examination. We see them if they say the hearing is the same, tuning forks are the same, we'll get an audio at 6 months. So maybe for the first 2 years as surveillance, an audio every 6 months just to take a look. If everything is stable, then after that, the patient is going to self-monitor and come back to us if something new develops. And this is still guided by the limited resources that we have. We have one audiologist and they are serving a huge catchment area with referrals from out as well. So in order to prioritize that, so we'll do 6 months, and then after a year, if nothing has changed, then you're going to self-monitor. But if you get in my unit, you don't need an appointment to come in and see us. You just come in. So if you do feel any new symptoms, any new hearing loss, anything in the opposite ear, we'll give you a list of red flags to look out for. You just come back to us, and we usually are able to see you within a week.
Yeah. Well, as you mentioned, I think one of the challenges, particularly, worldwide, particularly if we think about resources or availability or lack thereof, I think one of the things is, how do we adhere to a standard of care to optimally treat these patients in the setting of what is available in any given location around the world? So, what do you think? What are your thoughts on that in terms of guidelines, or how can we go about that, optimizing patient care, but then obviously within the confines of resource availability?
Well, I think we unfortunately, we don't have a quick answer to the resource limitations, but I think we can always get guidelines that are within the available resources. Of course, prioritizing patient safety, but there is always a lot that you can do with the little that you have. And as you get more, then we can always adjust these guidelines. Many years ago, we never had an MRI in my hospital, but now that we are able to fine tune a few things to be able to provide better care for our patients. So the guidelines have to be center specific and within your resources. It makes no sense at all to have a guideline that is out of your resources, because it's not going to happen. But if it's within what you have available, then you can always fine tune that when you have additional things come in. And once in a while, things come in. So once you have a newer service, then you can always edit and fine tune to provide better care for the patients. As long as we prioritize patient safety, I think we can always fit within what we have available.
Yeah, that's great. Well, thank you, Amina, for your time today. This is wonderful. I think the take-home messages here is that obviously there's common problems that we all deal with no matter where we are on the planet, but it's our capacity and resource, availability that really will sort of impact the patient's care. And I think it behooves us across the globe, when we can, to think about how can we still optimize patient care and safety, as you've said, despite those resources. And I think this is a hot topic that the Academy and the world is really trying to tackle going forward, so that we can still, meet our patients' needs. So thank you so much for your time today, and best of luck.
All right. Thank you so much. Thank you for having
Thank
me.
you. You bet. Thanks, Amina.
Good morning, everyone, and thank you to the AAO-HNS Humanitarian Committee for this opportunity to speak with you. I'm Dr. Siva Chinnadurai. I'm a professor of otolaryngology at the University of Minnesota and the director of ENT, facial plastic surgery, and audiology at Children's Minnesota. And I'm so honored today to be joined by my longtime friend and colleague, Dr. Kassaw. He is the head of the Department of ENT at Bahidar University in Bahidar, Ethiopia. His institution is home to one of 4 residency programs in the country of Ethiopia, and it's the site of the first Ethiopian pediatric ENT training program, which we have worked hard to build together over the last several years.
Thank you, Professor Siva, and thank you all for being here. Today we will use a shared case to explore a neonate with congenital stridor into very different clinical setups, and that will tell us something around the global surgical education. Thank you all.
Thank you. So let's thank you, Dr. Kassaw. Let's dive in with our clinical story. And, you know, this is a very common case we see in pediatric otolaryngology. Say we had a 6-week-old infant who was presenting to us with inspiratory stridors since birth, but his baby's feeding well, but they're really loud when they're breathing, both when asleep. It's more pronounced when they're crying. Their parents are very anxious and bring this child to us for evaluation. In the United States, this infant would be seen in a specialty clinic, maybe pediatric otolaryngology or a multidisciplinary airway clinic. It's very likely that we would perform flexible laryngoscopy as our first diagnostic test in the clinic. We would typically capture this with video documentation, which we'd review with the family. And depending on the clinical setting, how the child's doing, parents' level of concern, and our recommendations based on our findings, we might recommend some other studies, sleep evaluation, oximetry studies, reflux evaluation. In our setup, the parents will usually expect an answer the same day. And oftentimes the diagnostic tools, such as the endoscopy, are what provide the reassurance that nothing has been missed. How might this look in your setting, Dr. Kassaw?
Okay. Here in Ethiopia, we might also see the patients in the clinic, in the outpatient clinic, usually referred from a pediatric clinic. The pediatrician usually evaluates, and if there is any noisy breathing, they will link to our clinic. But the path afterwards may be different. We often do not have endoscopic setups here, so we usually rely on history and physical examination, careful history and physical examination. We will rely on the feeding status, weight gain, and respiratory effort of the infant. Sometimes we observe the baby while sleeping or while feeding, how its breathing is disturbed. We may follow the baby for several weeks, expecting the natural process of laryngomalacia if our clinical diagnosis was with laryngomalacia. If not, or if the symptoms are worsening, we may refer to the setups where endoscopic evaluation is available. If symptoms are mild, the baby is thriving, the families will be reassured, and we will educate the families how the baby's progress will improve over time. And we will also tell them the danger signs if there is any exacerbation of the respiratory stridor to come back to our setup. Otherwise, the endoscopic evaluation is not that much available, and we usually rely on this history and physical examination and watchful waiting.
Yeah, thank you, Dr. Kassaw. And you said something in your response that I wanted to pick up on, which is you laid out a great clinical course when the baby is following the traditional course for laryngomalacia, but you had mentioned if the baby is not thriving or not moving ahead well without intervention, you might refer them on. So what does that look like in your setup if the baby's not thriving, or you're worried there may be some other pathology that needs more evaluation or surgical management?
We don't have a flexible laryngoscopy in the government hospital, so we refer to the private hospital where the flexible laryngoscopy is available. There, the patient will be evaluated with flexible laryngoscopy. Then after, the patient will come back with the result of flexible laryngoscopy, but still in the government hospital, there is no pediatric suspension laryngoscopy. If there is any surgical intervention planned, there is no this pediatric suspension laryngoscopy. So we usually refer the child to the capital, Addis Ababa, for operative. If there is any operative need, we will refer to the capital, or we will give them a chance to go to private hospital for the intervention. Usually, patients choose to have operation at the private hospital. They don't want to go far for the procedure, and the procedure will be done usually at the private hospital.
Thank you. I think the overall course or treatment recommendations may be quite similar here, but we usually have a consolidation of those resources in the same facilities that would evaluate these patients. So here, if we had concern in the same hospital setting, we'd move to the operating room for what you've discussed, sedated endoscopy, look for other pathology. If we knew that the patient had a convincing history for laryngomalacia ahead of time, we would have discussed the possibility of supraglottoplasty with the family. And then we would go ahead and perform that operation during the sedated endoscopy if it was justified based on the findings. So it sounds like overall the medical treatment course would be quite similar, but the pathway to reach it is quite different. And that really brings up some of the differences in our practice. It really highlights and reveals different strengths and differences in resources between our two setups. And I think in the US, one of our big strengths is that we have immediate access to diagnostic and interventional tools, so it lets us streamline that approach. But along with that is the big risk of over-testing or committing children to over-aggressive or unnecessary interventions, and that's a fine line to walk.
Yes, and here in Ethiopia, clinical judgment is sharpened by necessity. We rely on observation and longitudinal care, but we sometimes lack the equipment to evaluate more concerning cases quickly, and in that case, we may miss the pathology without proper referral network and proper equipment, so we may miss the pathology, the diagnosis.
Yeah, these differences really raise a lot of important questions when we talk about global educational partnerships, and when we design teaching and training materials, when we design clinical modules like the ones that we've worked on. It really raises the question about which clinical model should we be teaching and developing.
Yeah, we have seen examples of international programs that assume access to scope, sedation, immediate OR intervention. But here, it is not existing. We don't get it simply. So the curricula can feel disconnected, or it can be frustrating to this local trainees here. It is difficult to continue if we see the international programs. It will frustrate us to continue the training here.
Yeah, that's a tough situation, and as we've seen as we've worked together, the goal in developing these curriculum and these training modules is not to really change or lower standards, but it's really to define what excellence means in the context that care is being provided. And so I think what we've discovered together is that means creating educational curriculum and teaching core principles, in this case, something like airway assessment, differential diagnosis, and triage, even if the physical tools differ in how we pursue those. And that's where the shared decision making and design in curriculum development becomes really essential.
Yeah, when both partners contribute, those who know the best settings and those who bring different perspectives, the curriculum becomes more useful, helpful, more sustainable, and more relevant. So that's why we have that.
Yeah, I couldn't agree more. I think the shared decision making in international education partnerships is based on asking questions and not assuming the answers. What we've done is adapt our materials, co-teach, and rethink what gold standard means in different contexts, in different places, in different cultural contexts. And that's how we try to ensure that international education is not an export, but it's co-created in the place where it will be used.
Perfectly. For example, our case today shows how different approaches to the same problem can both be available, can both be valid, and how those differences can strengthen education, this global education. If we design in partnership, we can make it more helpful, more visible.
Yeah, well, we hope that this conversation today encourages everyone watching to support bidirectional collaboration when teaching, when learning, and when building international curriculum. And we want to thank the AAO for the opportunity to present. And I want to thank Dr. Kassaw not just for the video today, but the years of partnership, the ability to work on education with him and his residents in his department over several years has certainly been the honor of my career. Thank you very much, Dr. Kassaw.
Thank you, Professor Siva. Thank you for giving me the chance. Thank you so much.
I want to thank each of you for working with your colleagues across the globe, as everyone can see, to develop these conversations on topics that are so important in the otolaryngology world, and how those are managed, and how you guys have worked to develop curriculum and to develop long-lasting educational routines. I'd love to hear from you guys each. If you could describe the biggest surprises when you have worked with your colleagues around the world, not only from what they have shared with you in terms of their resources and education, but also what you have been surprised and maybe brought back in your own practice back here in the United States. Dr. Sebelik, do you want to go first?
I would be delighted to, because that's a really, really wonderful question. If I may use their first names, Karen and Geraldine and I have become three such good friends. We've taught courses together in the Philippines. We've collaborated. Dr. Luna was just at an ultrasound course in Copenhagen this summer. We actually just did a course in an ENT residency program in Iloilo 2 weeks ago. And this is an ENT residency program that just got accredited, and they're so excited, and they're integrating point of care ultrasound right at the beginning in their curriculum. And so to answer your questions about things that I've learned, first of all, I think ENT training and ENT residents are the same across the globe. We all, as trainees and as faculty, we all face the same issues. We work too hard. We take too much call. We can't always get a hold of our attendings, and the clinical problems are always challenging. So ENT training across the globe is really not different. Disease states can be different. The severity of disease can certainly be different, But I love the fact that ENT residency training is the great democratizer. It's the same no matter where we are. I have learned things from my colleagues technically because they take what they have in their training programs and what they learn in teaching, and they generously share. So I can tell you I do a better percutaneous ethanol ablation of a thyroid cyst because Dr. Luna taught me how to do it better. So we have a very collaborative relationship. And I feel like we're spreading the word of POCUS as far and wide as we can. So I
Right.
appreciate you asking.
Dr. Basura, same question in terms of surprises that you have also gained and learned from as well.
Yeah, thanks for that. Great question. Yeah, I think that the surprises, I think the things I've learned or appreciated is how adaptable my colleagues in the developing world are and how they do a lot with a little. How they basically have educated themselves in a lot of ways on things that they may not have seen, or how they adapt some of the things we teach to what they already know or what they don't know. But I think what I've learned is technical surgical approaches, things that, like in ear surgery, we don't do a lot of endaral approaches. So, that's more of a European thing. They do a lot of those types of approaches, even, the gouge for the mastectomies, things like this. So I've learned so many things that they just find a way to adapt to the environment, and they do a lot with a little. But they're so receptive to learning new technique, and I think one of the biggest things that I think, as far as impact goes, is surgical simulation. And I know our last webinar with this subgroup was surgical simulation. I think that I was really surprised to see how much of a role that's now playing as we go forward. And then also, lastly, the last piece of this from an educational standpoint is just that desire to understand and how they can apply standardization across the board that are resource based. So I think that's a really big part of this going forward, is how can you recommend you do certain things with certain limitations to maximize patient care.
Yeah, thank you. And then Dr. Chinnadurai, same question in terms of surprises as you've learned from your colleagues over in Ethiopia and around the globe.
I really feel a lot of the same things in regards to flexibility and adaptability, both in terms of technical limitations like or equipment limitations like Dr. Basura was mentioning, but also how to adapt to different contexts of cultural care, things that are relevant, how to move through different priorities in different populations with grace and humility. And I think it's really easy in our practice here when we have, set standards or set ways that we do things to have some difficulty adapting that to different populations who we might encounter in our day-to-day lives. But seeing how our colleagues adapt and change that context has really helped me a lot in my flexibility to approach. I've certainly learned how to do a lot of techniques, along Dr. Sebelik's lines. I've gotten much better at vascular anomaly sclerotherapy with doxycycline and IV cannulas, and that's not something I've ever done in my practice here, but I have there. And I think finally the desire to do so much with so little in terms of resources really helps underscore the passion and the drive to do what we do and why we do it. I think we are fortunate to have a field that has so much opportunity, so much technology, so many new things to do, and also a lot of frustration, paperwork, headaches that go along with it. And to be able to see through all of that stuff and really connect to the passion of who we're helping and what drives us to do it, I think has been very meaningful for me.
Yeah. I love hearing all of those answers from all of you, because I think it really is what drives these collaborative relationships across the globe. Each of you talked with your partners about a common problem, an issue that you see regularly in your practice, whether it's airway or a neck mass or hearing loss, and yet we have these answers. You know, there are like the board answers that we have for how you work up sudden sensory neurohearing loss. And if you ask your resident here in the US and you would expect that they give this certain answer. And yet when you're dealing with our colleagues around the globe, their answers are different in some scenarios because they don't have the same resources that you might have. And so I want to hear just from each of you, and any of you can jump in first, but when you're talking about a common problem that you manage and you think that there's a certain way to manage it and it can't be managed in another setting that way, how do you approach that? How do you talk with your colleagues around the world with that? How do you address it? How do you teach and approach that when you're trying to educate them as well?
Well, I'll jump in on that, I guess, first. Well, I think one of the things I've learned is along the lines of, so if we talk about like medical tourism, where you start introducing things, I think you have to be careful. I think one thing I've learned is when you talk to your colleagues, you first ask them, well, how do you manage it? You know, you ask them what do they do? What's their standard? You know, wherever they are, what is it you do? And I think you open the discussion with that first, because I think it's dangerous to say, oh, so when do you get the MRI? Or when do you get the PET scan? Or, you know, these types of, I think it's dangerous. You can't, because you can't ever assume that they have that technology available to them. So I think one of the things that I've learned, the very first thing is, so tell me how you would manage that. What do you do? What's your thought process? And you let that sort of disclose sort of their workup. And it also it will also disclose sort of their resource availability and what they do and things like this. And then it opens a door for questions. And you say, oh, so do you ever consider imaging? So I think you ask questions instead of saying, well, this is what you should be doing, because I think that's a dangerous precedent, because you're also introducing concepts that they are and resource technology that they may not have access to. So I think it's important to ask what they do first and ask probing questions and then build from that. And then it also gives you an insight into maybe, are they working towards other resources, or what's the resource availability, or do they refer it out? And you can build from that conversation in a safe, culturally sensitive way.
Yeah.
I think the same goes for technological resources, not just in the clinical approach or how they talk to patients or how they move through, but when you think about the surgeries that we do, for example, how do you manage a child with Robin sequence and tongue-based airway obstruction? You know, in this, in our context, even over the last 20, 30, and 50 years, there's been a dramatic change in how we manage that child. And I think a lot of our partners and their local contexts are coming along in, you know, similar pathways of evolution in terms of their understanding and their access to technical resources to manage those conditions, but they may be in a different place. Even if they're on the same pathway, they're in a different place in terms of their access to technology, materials, time, money, proximity to travel. And those probing questions help. And one of the things that we talk about when we're building the curriculum in Ethiopia, and Dr. Kassaw brought up in the video, is they, along with folks I've worked with in other places, have kind of stumbled across working with groups over time who try to import that gold standard, not just in clinical approach, but in terms of technology. And it really doesn't contribute to sustainable capacity building. And so starting with those questions and approach and in terms of resource helps you build and find out where you can invest, both in people, in knowledge, where you can learn yourself, but also how you can diagonally approach this problem and invest in technology and capacity building over time.
I think I can address that by looking at access to imaging specifically with neck masses in the United States. every emergency room with a patient with a neck mass may automatically get a CAT scan, and that's great, but that's very expensive. And in many cases in our patients, they don't have adequate insurance coverage. There's pre-authorization. So our access to imaging is scarce for different reasons. In other parts of the world, as the World Health Organization has recognized, access to imaging equipment, radiologists, quality interpretation of imaging is at a severe shortage throughout many parts of the world. So I think my colleagues and I have recognized that having access to a portable clinician-held device that can be much less expensive and more immediately employed has really sped the workup and the accuracy of patients with neck masses and similar conditions. It is so interesting that we've followed parallel courses in our zeal to teach surgeon-performed ultrasound for basically the same reason. Other kinds of imaging is sometimes hard to get, or sometimes too expensive, or is simply not timely. And so, yes, scarcity of imaging varies around the world. And this is one of the solutions that my colleagues and I have come up with, and we're certainly trying to spread it as much as we can.
Right. So in your guys' previous discussions, you all have made note to some curriculum opportunities and working around the globe, developing curriculums with your colleagues. If you guys could just comment on how do you work with your global partners to develop a curriculum that will work for them locally? Because I know we get asked that sometimes. They, will you help us develop an educational program for our own residents? And how do you guys take that approach when you're helping to develop that curriculum in a part of the world that has different resources than what you would traditionally be working with? And Dr. Sebelik, why don't you start first this time?
That's a great question, because I think that, and it's already been brought up a couple times, that teaching a technique that involves recognizing anatomy and manipulating the tissues is really ideal for simulation, either simulation on models or simulation on each other. The developing the curriculum for head and neck ultrasound has been pretty great. I've learned more about making low-cost simulators from my colleagues, and they don't have, and neither do we, quite frankly, don't have the money for many hundreds of dollars of phantoms, but we sure can make things that are very inexpensive from the market. And so developing the curriculum for head and neck ultrasound has been a very lovely joint effort, because we all know the anatomy. We all know how to read a CAT scan ideally, and ultrasound helps tremendously with that. So we have found that ENT residents, when you have a curriculum that's based on things they should already know, it goes very quickly. ENT residents pick this up so quickly, no matter where they are.
Dr. Chinnadurai?
I think one of the goals we have in curriculum development is really to create a curriculum or a fellowship program that can produce a trainee that is recognized nationally or internationally as an expert in that field. And so when we do that, we want to be careful that we're not straying too far from the standards of what defines a head and neck surgeon or an otologist or a pediatric otolaryngologist or any other subspecialty. But to do that, we start from a common starting point, which is looking at milestones and metrics that are widely accepted as a starting point for discussion and some of those probing questions. But it's not a one size fits all, and it's really important to define excellence in the context that it's provided in, and whether that means access to scopes, sedation, audiograms. we really have to figure out what excellence is in that context. And part of building these programs, not just at one site, but is creating a healthcare community or a referral network where you figure out where's the center, where are the hubs and where are the spokes. Just as we have in the US, not every center does everything at the same level of excellence. And so if we're looking at pediatric otolaryngology, we want people who are extremely skilled at all of the things that kind of define the basic needs of a pediatric otolaryngology program. But not every center is the hub for, say, open airway reconstruction or cochlear implantation. You have to make sure that the places that you're investing in to do those things, one, can perform them at a high level with high standards, but also you're building the curriculum in a way that it's shared, that others could come and learn from that center so they can learn in the best context that's available and take those skills out and be champions in their own areas for building the frameworks around that. Because you can't build everything everywhere all at once. And so if you create those centers and make them open to others to learn, that'll carry the message a lot further.
Right. Thank you. And Dr. Basura.
Yeah, so I think you get feedback, really. So right now, the example with the hearing loss guideline, we're actually creating that guideline as we speak. And that's been created by a committee, put together by my African colleagues. And so that's basically built on feedback from people from all over different countries and how they manage it, and then coming up with some kind of a consensus statement or a guideline. The way I see it, there's two ways of doing it in kind of the resource stressed areas. One is that way where you get feedback across multiple representatives from multiple areas, and you come up with some kind of consensus approach. Or the other way, which is brilliant, which Dr. Johan Fagan did with some of the head and neck guidelines, is he created a grid where he said, okay, if you have a thyroid mass, here's what you do. If you have access to TSH, you should do this, and an ultrasound. Or you don't have that, then you should get to all you have is maybe a TSH. Okay, get this. And what it does is it guides people based on their resources to have a standard. So the standard is still to optimize the care, but that's all contextual based on what you have available. And so I'm trying to create a hybrid in that regard, where we're trying to create, by getting broad spectrum feedback from resource constrained areas and how people would do things, and then create some kind of overarching guideline that really highlights those resources in that regard. And then opening up to a big forum, for example, the African Otologic Society is how we present that. So then we present it out at an open forum and people can then comment on it. So it's a really nice way to sort of build those types of educational guidelines.
Right. As we get ready to wrap up this wonderful webinar, one final point from you guys. I'd love just to hear any final thoughts from your guys' areas of expertise on bidirectional education and developing these, curriculums and teaching abilities across the globe with all of our partners. Any final thoughts from any of you guys?
I think whether that is coming from us, from the United States, or from our colleagues in lower resource settings, our goal is not just to teach students, but to teach people, to train. We need to have a legacy of continued development of teachers in the future. So training the trainers is a critical part of any education that we embark on. It's not just showing up and doing a course for some eager students, but also supporting young faculty, supporting the new educators, and promoting continued development of trainers to make our future generation of teachers. It's that's the most that's the best way we can make our efforts wide ranging and ever increasing.
Yeah, I totally agree with Mary. I think when we are looking at developing those curriculums, that bi-directional feedback helps us not only train the clinical skills, but figure out how to set things up financially, politically, socially, so that those training programs are sustainable, not just from a clinical practice standpoint, but that they fit well into the context, and the local authorities are supportive of that and can sustain it over time. And to really raise the profile, one of the things we've incorporated into our fellowship, and I know many of my colleagues have done so, including those on this call, is figuring out how to raise the profile of the people we're training and the trainers we're training through research, academic productivity, visibility on the national and international stage to build their reputation, so that we can draw in enthusiasm, support, and the next generation and the generation after that of students who want to learn and carry this on.
Yeah, I think one of the things is stewards of education for the developing world that we try to, help with is we have to publish our data. We have to publish these outcomes. We have to publish them in ways, though, that are reaching those communities, though. And so one of the things that we're starting to see more is journals like Journal College of Medicine of South Africa has a free publication. They don't charge the author. So they just, if the data is good, it's published. And I think that's going to become more and more critical, but we have to publish this stuff in resource constrained areas. We have to look at what's our outcomes. Are they working? But we have to get those to the audiences that matters, that's targeting in those resource constrained areas, so that we can look at, it's one thing to do all this stuff, right? But we have to look at our outcomes. Are we making a difference? Is this, and really look at that and study that, just like we do anything else, and say, can we do this better? How can we do this better? So I think by targeting those types of things and getting the word out in those specific areas, I think we can really build on this and build consensus that can be really helpful for the future.
Well, I want to thank each of you tonight on this panel for joining myself on this webinar. I know that all of us here could talk for hours on this topic, and unfortunately, we do have to wrap this up. I also want to thank your partners across the globe who joined you for your videos, because I know that took a lot of time and effort, and I know I did, and I'm certainly everyone else who watches this webinar will learn so much from just hearing their own voice and what they explain and what they want to teach us, just in those few minutes that we get to hear from them. I want to give one last shout out again to the American Academy of Otolaryngology Head and Neck Surgery for sponsoring this, and specifically the Humanitarian Efforts Committee, and also our amazing staff, Katie, who had helped put this together. She makes our committee run, and just want to give her a special shout out as well. And with that, I want to thank everybody for joining.